Hello, I want to thank everyone for joining us today and welcome to today's webinar for mental health professionals, How Science Can Be Used to Transform Treatments for OCD, featuring ADAA board member Dr. Blair Simpson. Please note this webinar is being recorded and will be available as an on-demand webinar within 24 hours. I'd like to briefly introduce myself. My name is Sasha Sicard and I'm the Education and Membership Manager here at ADAA. Thank you all for joining us today. Before we get started, I would like to go over a few items so you know how to participate in today's webinar. You have joined today as a participant and as such will be muted for the duration of the presentation. We've taken a screenshot of an example of the attendee interface that you can see here. You will have the opportunity to submit text questions through the Q&A feature featured in your attendee interface. You may send in your questions at any time. We will collect these and address them during the Q&A session at the end of the presentation. For this webinar is being recorded and available on demand. For those who will be applying for the CE credits, you'll receive an email directly from me this afternoon with a link and instructions for completing your credit requirements. I would like to now introduce Dr. Simpson. Dr. Simpson is the Vice Chair for Research and Professor of Psychiatry in the Department of Psychiatry at Columbia University. She is also Director of Psychiatric Research and of the Center of Obsessive Compulsive and Related Disorders at the New York State Psychiatric Institute. Funded by the National Institute of Mental Health since 1999, she uses clinical trials to identify the best treatments for anxiety and obsessive compulsive disorder, and partners with basic and clinical neurosciences to elucidate how the brain produces anxiety, obsessions, and compulsions. Funded by NIMH, Dr. Simpson is collaborating with OCD experts around the globe to identify brain signatures of OCD. Dr. Simpson has been a member of ADAA since 2003 and is currently an ADAA board member. We're so glad to have you here today, Dr. Simpson. There will be a brief moment as I pass the presenter role over to her. Dr. Simpson, you may now share your screen.
Thank you so much, Sasha, for that introduction, and to all of you who are joining us today to listen to my presentation. And I'm going to talk about how science can transform treatments for OCD. So as Sasha told you, I direct the Center for OCD and Related Disorders at Columbia Psychiatry in New York City. And the mission of the center is to transform treatments for patients with OCD and related disorders by conducting patient-oriented translational research. And what that means is we use clinical trials to test what are the best treatments for OCD, and we partner with neuroscientists to study what causes obsessions and compulsions with the goal of identifying novel treatment targets. So in today's talk, I'm going to briefly review the clinical features of OCD and data that support our first-line treatments. If you will, it's a quick primer on OCD if you're a practicing clinician. And then I want to highlight two clinical problems in the field and illustrate different ways we're working to solve them. And my ultimate objective is to illustrate different types of patient-oriented translational research and show you how this type of research not only can solve these clinical problems, but in fact is essential for advancing clinical care. So what do I mean by patient-oriented translational research? And that's what I'm showing you on this slide. So for me, it means all of these different types of research. So it means translating from basic science, latest advances in how the brain functions. It means using genetics or brain imaging or studies of the environment to identify mechanisms and targets for intervention. It means using clinical trials to test and improve current treatments, and that could include psychotherapy or medications or neuromodulatory treatments. And finally, and very importantly, it also means implementing and disseminating what we learn out into the community to real clinical practice. So today I'm going to tell you about some of our work here with clinical trials, how that led to work in implementation science, and how that's also led to work in understanding mechanism. But first, let me start, just to make sure we're all on the same page. What is OCD and how do we treat it now? So the hallmarks of OCD are pretty straightforward. The core features are obsessions and compulsions. It's right in the name, obsessive compulsive disorder. Obsessions are repetitive thoughts, images, or urges that are intrusive and distressing. compulsions or repetitive behaviors or mental acts, thoughts people do repetitively in their head. And the goal typically is to sort of reduce anxiety or seek reassurance. Importantly, the symptom, we all have an occasional intrusive thought, and many of us have little habits that we do. That's not OCD. OCD is when these symptoms, these obsessions and compulsions are distressing, time-consuming, and impairing in functioning. The other thing is that OCD, even though it has that very sort of core aspect of it, there are also these associated features that can give it clinically a fair amount of heterogeneity in its presentation. So for example, there's a range of content and fears that patients can have, and these have been called so-called symptom dimensions. They can, one patient can have obsessions and compulsions very focused on contamination concerns. A second one could have concerns about harm, a third about symmetry, exactness, although many patients have symptoms in different dimensions. But that gives a lot of flavor and a character to OCD as a disorder. The other thing is people with OCD can have different affects. While many have anxiety and can have panic attacks, others have a sense of just things are just not right. Still others can have a sense of disgust. Patients with OCD can have varying insight, with some people really understanding that their obsessions don't make any sense and they shouldn't really need to do their compulsions, but they're sort of doing them anyway. Whereas others can actually really think that if, for example, they touch that doorknob, they might get sick and die. So there's varying insight. And finally, various comorbidity. The most common comorbid conditions that people with OCD have are anxiety and depression. But in kids, you can also have tic disorders or ADHD, and eating disorders can also come along for the ride. I love to emphasize how disabling OCD can be, because I think sometimes it's been a hidden disorder and people have minimized it. For people who suffer from OCD, this is not something to minimize at all. The lifetime prevalence is about 2%, so it's twice as common as schizophrenia, but receives far less funding in research, at least in the United States. Half of the cases in epidemiological studies start by age 19, and in comparison, half of the cases of major depression are age 32, and about a quarter of cases start by age 14. When people get symptoms, typically, not always, but typically the disorder is chronic with waxing and waning symptoms. And importantly, if you've got a diagnosis of OCD, chances are you've got moderate to serious symptoms. There are much fewer cases that are on the mild side. So if you add all that up, the prevalence, the age of onset, the fact that it's typically chronic, and the fact that when you have it, the symptoms are more likely moderate or severe, that's what makes OCD such a disabling disorder for so many people. Now, the good news is we have first-line treatments for OCD that work, and they come in two general classes. One are medications called serotonin reuptake inhibitors, or SRIs, and I list them here. They include clomipramine, which is, if you will, an old-fashioned antidepressant, but it has a lot of serotonin reuptake inhibition in it. And then all the selective serotonin reuptake inhibitors, and I've listed the generic names here. And all of these work, even if they're not all FDA approved, and that's been shown in randomized controlled trials. The other class of treatment that we know works for OCD is cognitive behavioral therapy, but of a particular type. It's been called exposure and response prevention or ritual prevention. It's got a lot of different acronyms in the field. You're going to hear me call it exposure therapy or EXRP or sometimes CBT, but I mean this specific therapy. So what is this therapy? So it has sort of two key procedures, which are right in its name again: exposures, which is the EX part, which you do either live exposures with a person of things that they fear, or you do imaginal exposures in their head. You make up stories about exactly what they fear, and you do the exposure on that story. The other component is ritual prevention, where you teach them to both monitor their rituals and then how to stop them. And the goals, there are different philosophies about how EXRP works, but in general, what we think we're doing is we're using these exposures to disconfirm their fears and challenge distorted beliefs. We're also breaking the habit of ritualizing and avoiding, and obviously fundamentally our goal is to improve functioning and quality of life. There are many different formats by which you can deliver EXRP. A typical one that we've used is 2 planning sessions plus 15 exposure sessions. And a real key to the treatment is daily homework that the therapist assigns to the patients, as well as the therapist going into the person's home to promote generalization of what they're learning. So I want to briefly tell you about a series of randomized controlled trials that we did at Columbia in collaboration with Dr. Edna Foa at the University of Pennsylvania. So what is a randomized controlled trial? It's the gold standard way to test what treatments work and whether they're safe. These are the sort of trials that were used, for example, to test that the COVID-19 vaccines work and are safe to deliver. And that was what was done before any of us were given access to them. And a typical design of a randomized controlled trial includes randomizing people to different treatments or to a placebo treatment or to no treatment. It involves always carefully trained study personnel to deliver the treatment as intended, so that you know that the treatment was delivered with fidelity, and to use evaluators of the outcomes who are blind to randomization. So they don't know what treatment the person got, and they're evaluating them, as I said, blind to knowing that. So the first randomized controlled trial I want to tell you about asks the question, we have these first-line treatments, serotonin reuptake inhibitors and cognitive behavioral therapy consisting of exposure and response prevention, but what's best? Because that's what a practicing clinician wants to know. That's what a patient wants to know. And the study asked, well, we recruited OCD patients. Some were randomized to a serotonin reuptake inhibitor. At that time, it was clomipramine we used. Others were randomized to the exposure and ritual prevention, that particular type of cognitive behavioral therapy that I told you about. A third group got the combination of both those treatments, and a fourth group got a pill placebo. So let me jump to the results. So what I'm showing you on the x-axis is OCD severity. A typical measure we use in OCD research is something called the Yale-Brown Obsessive Compulsive Scale. It goes from 0 to 40, with a higher score being worse symptoms. Typically 16 and above we consider to be moderate OCD and warranting treatment. On the x-axis, I'm showing you weeks in treatment because all of the treatment interventions that I described to you were delivered over these 12 weeks. And then what I'm showing you is that in yellow are the people who got a pill placebo, a sugar pill, and you see that they had very little change in their symptoms. So people entered here with moderate to severe OCD on average. People who got a sugar pill, shown in yellow, had very little change in their symptoms. People who got clomipramine, an FDA-approved medication at that time for the treatment of OCD, had a nice slow decrement in their symptoms over the 12 weeks they were on the medication. And that curve almost perfectly mimics the trial that got clomipramine approval by the Food and Drug Administration in the United States. That's the FDA. But I really want to point out to you, look at what happened for the two groups who got exposure and ritual prevention. The treatment was delivered, those 17 sessions were delivered in the first 4 weeks. And then they got 45-minute maintenance sessions out to 12 weeks. And look at the incredible decrease in their symptoms, whether they got the exposure and ritual prevention treatment alone, or whether they got it in combination with starting the medication. So what you can see, you don't even need statistics to see it. You can see it with your eye. If you got exposure treatment with or without the medication, you did better than clomipramine, but clomipramine did better than pill placebo. But here's the thing, even though these curves of this exposure therapy look really good, at least in the United States, exposure therapy is hard. There's very little access to it. Way back then, there was very hard to get access to it. There's a little better access now, but it's still hard to access. So what most patients receive first for OCD in the United States is a medication. And that means that most patients, even after a trial of medication like clomipramine, still will have symptoms. And if you notice, on average, the symptoms they have are actually higher than that blue arrow, so that they, even though better, they could still re-enter the trial at the end of the trial, even though they were better. So that led us to the next question. So and again, a clinically relevant question, you've put your patient on a serotonin reuptake inhibitor, they're better, but they still have symptoms. And that's going to be true for most of your patients that you put on a serotonin reuptake inhibitor. What do you do then? So for OCD patients on an SRI, but who still have symptoms, if you added that therapy, the exposure and ritual prevention therapy, then is that better than adding a psychosocial control, another therapy? And the reason why you compare therapies is because maybe just time and attention from a caring therapist might be good enough. We wanted to test the specificity of the effects of this cognitive behavioral therapy. So now this was quite a different design. Here we're recruiting people already on a medication, and they'd already been on that medication at the maximum dose they could tolerate for at least 12 weeks. And then we randomize them to either a psychosocial control therapy or that exposure and response prevention therapy, both delivered this time twice a week for 8 weeks. And let's go to the results. So once again, on the y-axis is OCD severity as measured by that Y-box measure. 16 and above is considered moderate to severe OCD. On the x-axis, I'm showing you treatment week. In this study, it was 8 weeks of treatment with a therapy delivered twice weekly, again, to balance out to those 17 sessions. Each therapy had 17 sessions. This is a different group of people. They're on a medication. They reported some benefit from the medication, but look at how symptomatic they still are on average. Those then who got this psychosocial control, and what we used was a stress management therapy, had very little change, as you can see by the yellow line. But look at what happened to the people who got the exposure and response prevention. Once again, a very nice decrement in their symptoms, resulting in minimal symptoms on average at the end of treatment, with 74% of people responding and a third of people actually ending up with what we consider remission, which is a Y-box score of 12 or less. So that was very exciting, but that led to the next study. And this is the last randomized control I want to tell you about. So this was, okay, so we showed that adding exposure and response prevention treatment to a patient who's having symptoms despite an adequate course of a medication, but how does that compare to what we psychiatrists typically do, which is to add another medication, not to add therapy, but to add another medication? And the medications that have been proven in their own randomized control trials to be effective as augmentation to the SRI medication are antipsychotics. And at the time that we started this study, risperidone was the one that had the best evidence with the least side effects. So this was a study which was designed very much like the last one I just told you about. We recruited OCD patients on an adequate dose of a serotonin reuptake inhibitor. They were at their maximum dose for a minimum of 12 weeks to make sure that they had really gotten the most they were going to get from that medication. And then patients here were randomized to either the addition of cognitive behavioral therapy using exposure and response prevention, or the addition of risperidone, or the addition of pill placebo. And the pill placebo there was to make sure that everyone, that the independent evaluator, everything was honest, because there were people there still receiving placebo. So let's jump to the results. By now you'll probably understand this graph. Hopefully the y-axis again is OCD severity, 16 and above being moderate to severe OCD. Treatment week is on the x-axis, 0 to 8. Everyone entered already on a serotonin reuptake inhibitor, but still had significant residual symptoms. First focus on the yellow line, that was the pill placebo. You see that those people who got pill placebo added on top had very little benefit. Then focus on the blue line. Do you notice how similar that line is to the prior study I showed you? Even though this is a brand new study, 5 years later, a completely different group of patients, a completely different group of therapists. We were very excited to see this because you rarely have the opportunity to do replication studies with psychotherapy. But this beautifully replicates the prior study and gives us even more confidence in the results. What was surprising to me in this study actually were the effects for risperidone. You see there the red line. I actually expected the risperidone to be where that asterisk is, not right up, nestled up close to pill placebo. And I think there are a number of reasons for that. And I think the biggest reason for that is that antipsychotics don't help all patients a little bit. Antipsychotics help about a third of patients a lot. And in a study like this, if we had we recruited people and randomized them, you know, our response rates for risperidone were about 23% instead of the prior studies showing about 30%. So we're not that far off, but we probably recruited just enough more non-responders to antipsychotics than responders, which is why we didn't show this difference. The point is, this study does not prove that antipsychotics don't work. That's not what these data show. There's a body of literature that shows that antipsychotic augmentation can work. But the important thing for clinicians to know, the take-home message is, they only work in about a third of people. So if you're going to try antipsychotic augmentation in your patients, try it for 2 or 4 weeks. And if it does, expect that 2/3 of your patients aren't going to respond to it. And if they don't respond to it, take them off of it so that you don't expose them to a lifelong history of antipsychotic for no benefit. But I want to go back to the good news. The good news is we have another really powerful augmentation treatment, which is the addition of exposure and response prevention, which once again can lead to many people getting better from that addition of that therapy. And in this study, 43% ended up with minimal symptoms. Sometimes I get asked, it's a side point, sometimes I get asked by clinicians, oh, well, should I use risperidone if the OCD is more severe? Maybe therapy only works when you add it to people who are less severe. I don't have time to show you the data, but it's exactly what we did not find. We found that exposure and response prevention worked regardless of your baseline OCD severity. It wasn't how severe you were at baseline that mattered. What mattered is whether you could adhere to the treatment. That was the key issue. Whereas with risperidone, we actually found the opposite. We found that people with less severe symptoms actually did better with risperidone. So where does that get us? So what I've just told you about is 3 randomized controlled trials, which are a very particular type of patient-oriented research. And they really are what teaches you what treatments work. And what we've learned, not only from the trials that I've just showed you, but from other people's work as well, is that serotonin reuptake inhibitors like clomipramine, many patients will respond, but response is usually partial. You don't get, on average, you don't get people well. And you're always, as a clinician, going to be needing to think about, well, what do I do next? So what are we doing about that, we and others? We're testing new medications in clinical trials, glutamate modulators, cannabinoids, psilocybin is now being tested, and anti-inflammatories. So stay tuned. Hopefully we'll have new options soon. What have we learned about exposure and response prevention from studies like what I showed you? That more will respond than will respond to the medication, but there's a problem with exposure and response prevention, at least in the United States. Access is limited and patient adherence is key. You're not going to get the results I just showed you if patients don't do their homework. So what are we doing about that? We're using technology to see if that can improve access, like internet CBT and mobile apps. We're testing those. We're thinking about how can we enhance learning from the psychotherapy. We've been testing things like novelty enhanced extinction. And many of us also use intensive formats to really help with adherence. This is, there's a super intensive version of this now being done in Norway called the Bergen method. And finally, when you put these first-line medications and this first-line psychotherapy together, when it's SRIs plus EXRP, the data show that you can get up to 50% of people to have minimal symptoms at the end of treatment. That's pretty remarkable. And as soon as that happens, the very next thing my patients ask me, can I come off my medication? And that's the 4th study that I don't have time to show you, but the results are just coming out. And the quick answer is We asked 2 questions. Does offering more sessions increase remission rates? Indeed, it does. If you take people who aren't remitted with minimal symptoms after 17 sessions and you give them only 8 more sessions, you can get close to 70% of people remitted. That's pretty remarkable for such a disabling disorder. And the second question we answered is, can those who remit then stop their medication without worsening more than if they had stayed on it? And the quick answer to that one too is yes, but with some caveats. Okay. This whole type of patient-oriented research, all of these different types of randomized controlled trials, build a body of knowledge, as I said, about what treatments work. And by now, we and others have done so many different randomized controlled trials, testing so many different types of treatments, different medications, psychotherapy, neuromodulatory treatments like transcranial magnetic stimulation. All of that data from those trials can then lead to treatment algorithms like this, where you can actually map out what's a first-line treatment with the best effects. What do you do if that doesn't work? What do you do next? So the details here is not why I'm showing this slide. There are too many details matter, but it's to show you that this is what is, if you will, the way to transform clinical care out of this type of patient-oriented research. Again, saying it that this type of patient-oriented research, in this case, clinical trials, advances clinical care by testing these treatments, finding out which ways work best, and developing these type of treatment or practice guidelines like the American Psychiatric Association did, all based on these data. Now I wanted to turn to 2 challenges in the field, and each challenge requires a different type of patient-oriented research to solve them. And I want to briefly use examples from my own research program to just, again, give concrete examples about these different types of research. So the first challenge is I just showed you that with our 2 first-line treatments, we can get up to half of people well. That's remarkable for an illness like OCD. But challenge number 1 is that most people with OCD in the United States, and I would argue in the world, don't receive these 2 first-line treatments. And there are many reasons for that. Sometimes it's because of the patient who doesn't come for treatment, doesn't know it's OCD, or can't access treatment. Sometimes it's the clinician who doesn't know how to detect and diagnose OCD or doesn't know what are evidence-based treatments for OCD. And sometimes it's the system. So for example, in the United States, a big issue is what's reimbursed and who has mental health treatment. We have a very fractured mental health system in the United States, and many people know what they want and can't get it or it's not paid for in their health insurance. So to address this challenge, my center is partnering with the Center for Practice Innovation in my department and with the New York State Office of Mental Health to try to take this on and do something about it. This is an initiative called Impact OCD, which is about improving assessment, care, and treatment for OCD across New York State. And our work follows the principles of implementation science. And the science of implementation, the process is engage your stakeholders, find out what they need, not what you think they need, and then develop training materials for what they need and study the outcome. So this is a completely different type of patient-oriented research than the randomized controlled trials that I just told you about. And my partner in crime here is Sapana Patel, who's here, who's an expert in this methodology, along with her colleagues in the Center for Practice Innovation. So what did we do? The first step in this implementation science approach was to engage an advisory board of providers and leaders across the state and ask, how does OCD present in their clinics and what do their clinics need? The other thing we did is we conducted webinars to do a needs assessment of frontline clinicians to assess with this webinar what they do and don't know about OCD and what they want to learn about, because the whole key in dissemination is you want to engage who you're trying to teach. The second step is we took that knowledge about what we learned about where the knowledge gaps were and what they wanted to learn, and we developed a training curriculum. And we developed different webinars about how to assess OCD, how to treat with EXRP, how to treat with medication, and also how to differentiate OCD from psychosis, specifically schizophrenia. We also developed OCD resources and a toolkit, both for clinicians and for families and individuals with OCD, because that's what the clinicians wanted. We got more advisors who gave us feedback on our training materials, including patients and clinicians. And we then developed also methods for evaluation. And we're now disseminating these training materials statewide. But again, it's a science. We're evaluating the outcome and the uptake of our training materials. If you'd like to learn more about this initiative, there's a whole website that's front-facing that you can access to learn more about it. And one part of that initiative, as I said, is this toolkit, and all of that is publicly available to anyone listening to this webinar. What we did is we curated, we didn't recreate all sorts of new materials. We curated materials across the field that were out there to give you sort of one place you could go. And part of the toolkit is for individuals and families, and the other part of the toolkit is for clinicians. And we'd love feedback on your toolkit, on our toolkit too. And you'll see that if you go to the toolkit, you'll see us evaluating how are we doing. That's one part of addressing the challenge of why people don't get evidence-based treatments. This part of the chat is trying to address how do we educate patients and families about OCD? How do we educate clinicians how to diagnose and detect OCD and even know what evidence-based treatments is? Another part of our initiative is actually to really think about how do we increase access to exposure and response prevention. In some senses, the medications is the easiest part of it because primary care physicians in the United States can prescribe serotonin reuptake inhibitors, and giving people a treatment algorithm of do this medication first, do that medication next, isn't so challenging. But actually getting patients access to exposure and response prevention is a big challenge. And one of the things that my center has been very focused on, as have other people, is can we use technology to increase access? And so we've been studying both clinician-supported internet CBT, and we've also been studying partnering mobile apps with clinicians to see if that can actually help reduce clinician time in delivering this treatment. And what's the fundamental goal? Our goal is to put together early detection by clinicians, by families and individuals coming to treatment and clinicians detecting them, and then making sure they have access to evidence-based care. And the two of those things then enable us to do early intervention for OCD. And that's our ultimate goal with this project in New York State, is to see if we could actually develop an early intervention program for OCD across the state. I want to now tell you about a second challenge that we have in the field. So I told you we have 2 first-line treatments that get half of people well, and the challenge there is how to get them out to clinical practice. But the other challenge is, what about the other half who don't get well with everything we have now? Anything I can give them in that treatment algorithm, and they're still not well. So that's a real conundrum in the field. And that leads us and others to ask the question, well, what causes obsessions and compulsions? With the idea that if we understood what caused them, maybe we could develop even better treatments for the people who don't respond to our current treatments now. So if you step back and think about what causes OCD, I think about it 2 different ways. I think about, well, pathophysiology, and by that I mean, how does the brain produce obsessions and compulsions? And the idea here is any behavior I do, ultimately my brain is actually letting me do it. So if I wave my hand, it's my brain that's allowing me to wave my hand, right? And there, the working model for OCD is that there's specific brain circuits that aren't functioning properly and that are leading to these abnormal behaviors that the brain is producing. And there's a whole range of different hypothesized deficits that could actually lead to obsessions, compulsions. And I've listed some of those there. But how the brain produces the behavior is a very different question then how'd the brain get like that in the first place? And that second question, how did the brain develop this problem? That's a question I think of etiology, fundamental etiology. And there, we're still working that problem out. There's some evidence that genes can put you at risk for OCD. There's certain metabolic causes. There's some data that certain infectious agents that can lead to autoimmune mechanisms can lead to new onset OCD. There's certainly data that very specific strokes in the wrong part of your brain can lead to new onset OCD, and also environmental causes as well, including trauma. I'm going to focus, though, this part of the talk on the pathophysiology. How does the brain produce obsessions and compulsions? And there's a large body of neuroimaging studies right now that demonstrate that people with OCD have alterations or abnormalities in a variety of brain circuits. And these brain circuits are known to underlie some of the hypothesized neurocognitive deficits that I showed you on the prior slide. But here's the problem with brain imaging studies, right? They can't distinguish cause and effect. So you take a person with OCD, you image their brain, you see something abnormal in their brain. You don't know whether the symptoms caused that abnormality in the brain or whether the brain caused the symptoms, right? The only way to do that type of causal dissection at this point would be using experimental animal systems. A second question is, well, do we think all OCD patients have the exact same brain dysfunction? I don't. My OCD patients have different clinical profiles. Some are more anxious, some are less anxious, some have different comorbidity. I actually think there might be sort of a core set of abnormalities that maybe all people with obsessions and compulsions have, but then there are different flavors of additional alterations they might have that might actually lead to the presentation than we see. But question 1 and question 2 are really hard to answer until we can actually answer question 3, which is, many of us have done imaging studies across the field. And, I do a study in 40 OCD patients and 40 healthy controls in New York City. And my colleagues, let's say in Brazil, do another study. And my colleagues in California do a third study. But rarely do we actually do the exact same study. So there's an issue of replication. And sometimes when we do the exact same study, the findings don't exactly replicate. So there's an issue in the field at large. It's not unique to OCD. Are neuroimaging findings robust and reproducible? Because only if they are can you start asking more questions. So that leads me to a very different type of patient-oriented research that I'm doing in collaboration with my colleagues all around the globe who are also OCD experts. And I'm so grateful for the scientific partnership. It has been a wonderful journey, although it's been very challenging, obviously, in the last year in the time of COVID, given that many of our sites are in places that have been horribly, horribly impacted by the COVID pandemic, as is unfortunately the whole world. Anyway, the aims of this study are to identify robust brain signatures of OCD. And our goal is to do that using neuroimaging, and then to link the abnormalities or alterations we find in the brain of people with OCD to their different clinical profiles. So now, why did we choose a global study? Well, because it's a really hard test of the hypothesis. What we're looking for is really robust signatures. And if we can find them not only in my OCD patients in New York, but also in Odile van de Heuvel's patients in the Netherlands, or Jonathan Reddy's OCD patients in Bangalore, India, or Dan Stein and Christine Loxner in Cape Town, South Africa, or Yuri Miguel and Rosalie Chavitz in São Paulo, Brazil. Now we have something really robust and reliable across countries, across research sites, across cultures. We've got a signature we could pursue, and we could potentially pursue that signature in either developing new diagnostic tests or using that as novel treatment targets. And what is this goal of this type of work? What's the ultimate goal? It's really towards something called precision psychiatry. And it's a very simple idea of precision psychiatry. If you will, my glasses are precision eye care. And the goal, meaning that if I gave my glasses to Sasha, she probably couldn't see the screen. But my glasses help me see my screen. So it's precise, my glasses are precisely oriented to my eyes, and they actually work only for me. So think about that same idea with psychiatry. Think about if we could link different signatures to different clinical profiles. Could we then develop even more precise treatments that target these brain signatures, leading to more precise treatments for individual patients? That is the ultimate goal. So that leads me back to the picture I showed you at the beginning of my talk, depicting different types of patient-oriented translational research. I told you about randomized controlled trials and showed you some of the data that we've done to make it sort of real and concrete. I told you about how those trials led me to partner with my colleagues to do implementation science to disseminate these treatments into community practice in New York State. And I told you about the neuroimaging studies that I'm doing with my colleagues across the goal to identify new targets for treatment intervention. And my goal was to illustrate how all of these different types of patient-oriented translational research, they address different questions, but each of them can advance clinical care. And I'd like to end by going one step further. I feel very confident that all of us listening today, if we thought about it for a minute, we all want better treatments. And we all want better treatments for all sorts of things. We want better treatments for cancer, for heart disease, for Alzheimer's disease. And I'm confident you want better treatments for mental illness too. And that's because we and our loved ones are going to have these illnesses. And we'd all like to have better treatments tomorrow than we have today. And the only way to get there is through research. It's the only way to change what we do tomorrow from what we do today. And that research must include not only the basic science that's done in a laboratory, and that is actually changing what we learn about and what we know about the brain, very important research, but that basic research needs to be complemented by the patient-oriented translational research, such as I described today, if we want to make sure that the advances in basic science get to our patients and change clinical care. And a particular way to think about it, a sort of obvious way to think about it is, think about the COVID-19 vaccines. We just watched over the last year a remarkable example of the power of science to develop, test, and disseminate that vaccine, and to develop, for those of us who have access to it, a potentially preventative treatment to this otherwise deadly disease. Imagine if we could accomplish something like that for severe mental illnesses like OCD. So with that, I'm going to close. I'm happy to take questions. I do want to do a shout out to my team in New York. We don't have an up-to-date picture. That's us doing our social distancing in Central Park at a picnic. But I'm hopeful that maybe this summer I can get a real picture of us all together, but not yet. With that, Sasha, I'll go back to you, and I'm happy to take questions.
Thank you so much. Let me just quickly share my screen. Great, and we did have a few questions come in throughout your presentation. We'll start with, have COVID patients suddenly developed OCD in your opinion?
You know, it's a great question, and the data are still coming in. I can tell you, we were just discussing this actually with my global team on the call today. Here's what I can tell you what we're seeing in New York. At the time of the COVID pandemic, when New York was shut down, we actually, the team really needed a group project to sort of keep up everybody's morale. And we were also very concerned about our patients. So we called back as many patients as we could from the last 2 years and asked them how they were doing, and if they wanted to work with us to just sort of see how they did over time. And we then evaluated them right in the midst of the surge in New York City, and then a few months later and a few months later after that. our data do not suggest that there was this huge worsening in our OCD patients. In fact, many of our OCD patients said to us that now they felt like the rest of the world knew how they lived. In fact, what we found is that our OCD patients, if they were getting treatment, actually could do very well in treatment during the COVID pandemic. If anything, I'm not saying that there weren't individuals who suffered. I'm not saying that. But this simple notion that, oh, a COVID pandemic will make people with OCD worse is not what we found. And I heard from my colleagues in India, Janardhan Reddy and his team, that they've recently published the same findings. It was their own experience from their patient population in Bangalore, India as well. And it's interesting, they told me that it was a little trouble getting published at first because the reviewers couldn't believe it. So the bottom line of it is, again, it's a good example of why science matters and data matters, because sometimes what we think is true isn't true until we test it.
Yeah, that's very interesting. We also had another interesting question come in, and they wanted you to speak onto the fact that the successes in your case presented clinical levels of OCD at the end of their treatment, given their Y-box scores are above a 7. She expressed some frustration that even the best clients still don't get to below subclinical levels.
I'm sorry, I guess I didn't understand the question. Let me be clear, which is when I say remission, that's Y-box less than 12, and we with EXRP can get Y-box to 0. When I first saw that, I can tell you I didn't believe it, and I actually went to check the records. So I'm not saying that 0 is common, but actually that's how powerful a treatment, exposure and response prevention can be, but it absolutely requires not only therapist skill, but it requires patient adherence. The most powerful factor, more than anything else that predicts good outcome, is whether patients actually adhere to the homework in between sessions. So now, a third of patients getting less than 12 still means that 2/3 of patients are getting above that. But then again, the data I didn't show you is that our recent data show that if you take people who don't get less than 12 in 17 sessions and you give them up to 8 more sessions, which isn't a lot more sessions, it's a total of 25 sessions, now you can get 70% of people to below a 12. I think it's a pretty remarkable outcome if you think about outcomes for schizophrenia or bipolar disorder, or you even think about outcomes for hypertension or diabetes, right? So I like to leave a message of, and now again, we're still focused, many people, we're all still focused on how do we get everybody there? And I agree with you that until everybody's there, we're not done. But I do like to leave a message of hope, both for the clinician and for the patient, that actually we do have powerful treatments for OCD, and we didn't have them when I first went into the field.
Mm-hmm. That is very interesting. Thank you. We have an additional question that came in that said, have any of the studies on OCD looked at the relationship between insight and the effectiveness of exposure therapy, and the possible advisability of focusing more on medication and less on exposure therapy for low insight patients?
It's a great question. So again, just to remind people that insight can vary in OCD patients. While many people have good, fair to good insight, you can see insight vary even inside a single client, if you will. And what I mean by that is someone can sit in my office and say, Dr. Simpson, I know, it doesn't make any sense and I'm not going to die if I don't wash my hands. But if I take that person in the old days before COVID out into the New York City subway, which in the old days was filthy, they're now washing it all the time, every night, but back then it was really filthy, and ask them to touch the pole right in front of me, they could lose insight and be convinced that if they touch that pole, they would die. So there's changing insight in a person when they're exposed to their trigger. There's also changing insight over the life cycle. So we've seen, patients, adult patient in her 30s, who in her 30s knew that, intrusive, negative, violent images about her family members were not going to cause violence. So she had insight that these images were OCD. But she reported that when she was a little kid, she was absolutely convinced that if she had a bad image about her parents, like in a car accident, she would kill them. So again, an individual person over the life cycle of OCD can change insight. Now to get to your question, here's the truth. Most randomized controlled trials, or I should say all randomized controlled trials, require a very elaborate process of patient consent. Patients with really poor insight into their OCD are not going to come into our trials because they don't have the insight to know that this is something they want treatment for. And even if their family member brought them, if they don't think they need treatment for it, they wouldn't sign the consent to go into the study. So there's been a lot of theoretical interest in what do you do with poor insight? Are those the people you use antipsychotics in? Are those the people you use medication in? I would argue that we really don't have good data on that in the field. What I can say to you, like I said before, if patients don't adhere to the exposure and ritual prevention treatment, you're not going to get the outcomes that I showed you. And so anything that interferes with adherence, patient adherence, is going to drop outcome. So that's why I often recommend when I see a patient who's very severely depressed, this is not a person I start in EXRP. This is a person I start with a serotonin reuptake inhibitor or other medications to really treat their depression. Once their depression is treated and they still have OCD symptoms, which the vast majority do, that's the moment to consider exposure and ritual prevention. And I would say, you know, you can use that same idea with poor insight. So there are adjunctive interventions to try to help people. Usually, sometimes it's cognitive interventions to try to help get people to better insight so that then they could do exposure and ritual prevention. And whether you do that through medication or whether you do that through cognitive interventions, you know, there's not great data on that, but those are two strategies that we've used.
Okay, thank you so much. We did lots of great questions are coming in, so I want to say thank you to everyone for participating. Based on the findings from the neuroimaging studies, what are some of the promising directions you see treatment outcome research going? Either enhancing or augmenting current treatments like exposure response ritual prevention or investigating novel treatments?
What I would say is that the neuroimaging findings and the treatment findings, we're trying to put them together. I don't think the neuroimaging studies are necessarily guiding the treatment studies yet, although that's the hope of the global project I told you about. But in terms of promising directions, you know, there are a lot of new medications coming down the pike, which are very, very interesting and challenging. So, for example, people probably have been hearing about glutamate modulators now for a while. That was a sort of a big idea a number of years ago with things like memantine and you know, there's now a randomized controlled trial of a novel glutamate modulator by Biohaven that's recruiting, for example. To date, I have not been like super excited by those so far, but that's a whole area of active investigation. And because the glutamate synapse is a very complex synapse and there are different ways to tap it. And so there's a lot of work there. Then there's a lot of interesting work in the endocannabinoid system. So that's the system, it's a natural system in our brain that we have in our brain that is also very fully loaded, the receptors in the same circuits that we think have been implicated in OCD. Some of our patients who smoke marijuana, because marijuana has cannabinoids in it, tell us that it makes them more anxious, and other of our patients tell us it helps them. So that's a set of studies that we and others are actually studying to see, once again, the science. Do cannabinoids or different types of cannabinoids or using cannabinoids in different ways, can that help OCD patients? There was a lot of excitement and still is a lot of excitement about ketamine, which has been used in depression, used in PTSD, has also been shown to be effective in OCD, although it has acute effects and then the effects go away. And there's just starting emerging, interest in drugs that affect the 5-HT2A receptor, which are drugs like psilocybin, which is, so I guess what I want to say is there's a lot more activity on the novel drug side than there has been in a while. And the other space to watch is the neuromodulatory space. There's a lot of active research on transcranial direct stimulation, transcranial magnetic stimulation, and deep brain stimulation. Really taking now this is where I guess the neuroimaging literature has been helpful, is looking at those circuits and thinking about how to modulate those circuits using those neuromodulatory treatments to see an effect. The first newly approved treatment for OCD by the Food and Drug Administration in the United States, the FDA, was it's called deep transcranial magnetic stimulation. And that was, I think, 2019, that's like the first new thing in a long time that's FDA approved. What's interesting though, if you look at that paper, you look at that protocol, it isn't just the TMS on its own. It's an exposure session with the TMS. And that is another interesting new scientific avenue that people are thinking about. Maybe TMS on its own isn't going to do much, but if you modulate a circuit that helps you now, for example, learn what you're supposed to learn in therapy, or helps you not have an urge to do a ritual, or helps you not be so anxious to do that exposure, that's a different way of thinking about combining TMS with exposure therapy. It's really using the TMS to help the brain take best advantage of the exposure therapy. That's an example. So there's actually a fair amount of work. And I think people with OCD, and I think clinicians who treat people with OCD, keep your eyes on the literature.
Great, thank you so much. We'll take two more questions. One of our last questions is, why doesn't the DSM clearly prescribe best practices? Can any clinician obtain informed consent without telling the patient of validated treatments and whether they are knowledgeable and capable of carrying them out?
So wait a second. So why doesn't the DSM, I don't know that I can speak to I think the DSM is really just a diagnostic manual. It's not meant to be best practices. The American Psychiatric Association that did produce the DSM had a program of practice guidelines. And I gave you that reference. It's the American Practice Guidelines for OCD, originally published in 2007. And then there's an online update in, I think it's 2013. We're obviously due for another update, but the question is whether the American Psychiatric Association has the funding, to pursue that. But I don't know that I can speak to why they haven't. There are other groups that have done practice guidelines, and there are good reviews. There's probably a good review about practice guidelines every couple of years. There's there edited books about OCD that also can give you treatment guidelines. And as I said, if you look at the slide, I gave you the link to Impact OCD, and we've put the treatment algorithm that we typically use in our center. We've put that up there as well as other resources. You asked, can clinicians
obtain informed consent without telling the patient of validated treatments and whether they are knowledgeable and capable of carrying them out?
So when you say, I don't know, I'm sorry, I'm not sure that I fully understand the question. When you say informed consent to me, a researcher, that's a very formal process, right? Which is, so if someone comes into my clinic, I don't even do the screening interview without having a consent form. And patients often find that sort of silly, because like, I came to talk to you, Dr. Simpson, why do I have to fill out a consent form? And that's because research has a very high bar. So I explain to them that this is part of research, and I need to tell you what I'm going to do before I do it, and I make sure that you understand and you agree, and then you sign the consent. So I'm going to say I'm doing a screening for a research study, And I want to make sure that you understand that that's what I'm doing. And then we sign the consent. So to me, and then if they were to be eligible for one of the studies, there's an even longer consent process and a separate consent for the study. I actually think in clinical practice, I mean, it's very formal in research. I actually think in clinical practice, the same thing is a really good policy with patients. I'm a big believer that explaining to patients what you're thinking about and what you're doing, what you're going to do, and having really clear guidelines and making sure they're engaged along every step of the way, you're going to get better outcomes. They're going to be engaged in the treatment. And most importantly, they're going to know why you're doing what you're doing. I can't tell you how many patients we see who, when we ask them, well, why are you on this medication? They say they don't know. Or we ask them, well, what were you diagnosed with? They say they don't know because their clinician never told them. Now, maybe their clinician told them and they forgot, but I do think that in clinical practice, sometimes it's looser and you write it in the note, but you don't necessarily explain it to the patient. And I'm a big believer that treatment is a partnership, and how you keep them in treatment and maintain the alliance and make sure that they adhere to what you are asking them to do is through that dialogue. I hope I answered your question.
Yeah, thank you so much. It's 1 o'clock, so I'm just going to say if you do have any additional questions, please feel free to reach out to myself. My email's right here, and I can send any additional questions over to Dr. Simpson. Thank you so much. I would also just like to invite everyone to register for our next upcoming webinar on May 13th. That's mentoring women in the context of gender, racial, ethnic, and sexual power barriers. And if you are not yet an ADAA member, we invite you to view the many membership benefits that ADAA has to offer, including year-long access to our continuing education webinars like this one, and the CEs are complimentary for our ADAA members. You can visit our website to learn more, but on behalf of ADAA and Dr. Simpson, I want to thank you all for joining us today. This webinar is being recorded, so if you would like to request the slides, please email webinars@adaa.org. Dr. Simpson, thank you so much for joining us today.
Thank you, Sasha, for inviting me. Thank you to the ADA, and thank you all for listening and taking really great care of your patients.
Thank you, and have a happy Mental Health Awareness Month, everyone.
That's right.
Have a great day. Bye-bye.